Hello, everyone, and welcome to our presentation on improving coordination between medical practices and prenatal and early childhood home visiting in Maryland. My name is Beth Barnett. I'm a practicing family doctor and professor at the University of Maryland Department of Family and Community Medicine. I'm also a member of the evaluation team of Maryland's Maternal, Infant, and Early Childhood Home Visiting Program. I'm very pleased to speak with you today about the benefits of strengthening coordination between primary care medical homes and home visiting for families in Maryland. In today's 10-minute presentation, we have three objectives. The first is to talk about the primary care medical home, what it is and what services a medical home provides to women, children, and families. The second objective is to identify the benefits of improving coordination between primary care medical homes and home visiting programs. The third objective is to share how evaluation findings are shaping a quality improvement pilot program that you will be participating in called We Care to Coordinate. The purpose of this We Care to Coordinate program is to increase coordination between a medical home, called University Family Practice, and two of Baltimore's home visiting programs, Baltimore Healthy Start and Drew Mondawmin. So what do we mean by care coordination? Care coordination is the deliberate or intentional integration of client and patient care activities between two or more participants involved in that client or patient's care. The purpose of this deliberate coordination is to facilitate the appropriate delivery of health care and other support services, reduce fragmented care, and improve the quality of care. When we speak about primary care medical homes, we're talking about a way of organizing primary care so that the care is more personalized, well-organized, and cohesive. A medical home strives to improve the health of individuals, families, and communities, and populations by providing accessible, comprehensive, and coordinated care so that care is high quality and patient and family centered. This map gives a view of the more than 70 home visiting programs across Maryland, shown in red and black. The yellow stars show where many of Maryland's primary care medical homes are located. As you can see, home visiting programs and medical homes are located near each other and may share the same clients and patients. What do home visiting programs and medical homes have in common? Both target communities with high rates of low birth weight babies, high risk for infant mortality, poor mental health and substance abuse, and child developmental delay. Both home visiting programs and medical homes focus on the same families to promote health, and both recognize that care and services need to be family-centered and pivot around families' needs, values, and preferences. So what are the benefits of better coordination? Better coordination would facilitate easier access to clients' immunizations, their health records, and their appointment information. With better coordination, home visitors could reinforce health messages, advice, and care plans. Better coordination would help medical providers gain a view into the family's home life, family strengths and risk factors, and the family's health needs. Both home visitors and medical homes could promote medical and home visiting appointment keeping, assist with transitions of care, encourage use of the medical home and not the emergency room. Coordination creates efficiencies, decreases service duplication, and reduces fragmented care. And ultimately, coordination may help reduce health and developmental disparities. I would like to turn towards how we can improve care coordination between home visiting and medical homes. Much of what we know about coordination we have learned by speaking with you and others around the state. Let me briefly review what the evaluation team has learned so far about coordination between home visiting and medical homes in Maryland. The evaluation has 3 phases, and we began it in 2014. In the first phase, we conducted surveys, focus groups, and interviews with key stakeholders that included home visiting program managers, home visitors, medical home leadership, medical providers, staff, and families receiving home visiting services. We wanted to know about how coordination, or lack thereof, was experienced. We asked about what home visiting programs and health providers know about the other, the degree of contact they have, reasons for the contact, whether they have policies regarding this type of contact, and their thoughts about the pros, cons, and challenges of communicating. We focused on describing knowledge, attitudes, capacity, barriers, and facilitators of effective and efficient home visiting medical home coordination. What has the evaluation found so far about the current state of coordination? Well, almost all home visiting programs ask families about where they obtain their health care, and most report some communication with medical practices. For example, home visiting programs often communicate with pediatric practices, but communication occurs less often with prenatal practices. The majority of communication with pediatric practices is to obtain immunization reports. Almost 90% of home visiting programs screen for depression, and more than two-thirds screen for substance abuse and domestic violence. All home visiting programs conduct child developmental screens. But home visiting programs rarely communicate these results to medical providers. And providers report that they don't know very much at all about prenatal and early childhood home visiting. Many have never heard of it. So there are lots of barriers to coordination. These include lack of knowledge, time, resources, and redundant requests for record release consent. Evaluation findings demonstrate that our current lack of coordination is really a missed opportunity. Primary care and OB providers in Maryland are generally uninformed about prenatal and early childhood home visiting services. Providers rarely know when their patients are enrolled in your programs. Even so, 100% of primary care providers said that receiving information about their patient's home environment would be very useful. Virtually everyone we spoke with and surveyed thought that better coordination could improve quality, efficiency, safety, and access. More than 80% of home visiting programs thought that sharing mental health information with the prenatal provider would be beneficial. Most believe that sharing child development screening results might reduce service duplication. But interestingly, home visiting programs report that in general, they don't ever receive any communication from medical practices, and similarly, medical practices report they don't receive any communications from home visiting programs. We believe that this may be due in part to medical providers being unaware of what prenatal and early childhood home visiting is, lack of knowledge that their patient is receiving home visiting services, and absence of infrastructure and other resources to support such communications. Our findings lead us to conclude that efforts to strengthen coordination need to focus on improving mutual awareness among providers and home visitors on the other's role, building relationships between organizations, arriving at agreement about the content of coordination, and establishing workflows through a designated point of contact called a care coordinator at the medical home. And ideally, the coordination should be easy to accomplish via an electronic infrastructure. In Phase 2 of Maryland's home visiting evaluation, we worked with leadership in your home visiting organization to develop a quality improvement intervention with new coordination procedures and workflows that we are calling We Care to Coordinate. And in Phase 3, we will implement and pilot these new procedures with 2 home visiting programs in Baltimore Healthy Start and Drew Mondamin, and a medical home called University Family Practice located at 29 South Packa Street. Part of the pilot involves the use of existing technology to create infrastructure that promotes and enables coordination to make it easier to do. We're working with Maryland's Health Information Exchange, known as CRISP, to develop this structure. This slide shows the home visiting and medical home sites participating in the We Care to Coordinate pilot. Let's talk about your critical role. When you enroll a new client and/or her baby in your caseload, please find out whether either the mother or her baby receive their medical care at University Family Practice. If so, share the We Care to Coordinate flyer and let her know she is eligible to participate in the care coordination pilot. Ask her permission to arrange a follow-up meeting with the We Care to Coordinate evaluation staff to discuss the program in greater detail. Explain that if she agrees to participate, better coordination will help her get appointments and other services that she needs. Participation will also allow her to be eligible for several $50 incentive gift cards for filling out surveys about her coordination experiences. The Medical Home Care Coordinator is your point of contact with University Family Practice. This slide shows a picture and contact information for the care coordinator. Her name is Claire Eberhardt. Claire is a social worker by training and has worked extensively in maternal and child health and home visiting. You can contact Claire directly. She will be happy to discuss the health and psychosocial issues related to your clients, relay relevant health information such as immunizations and upcoming or missed medical appointments, and connect you directly with the primary care provider if needed. What type of information do we think should flow back and forth? The primary care medical home should be informed when one of their patients, who is your client also, is enrolled in home visiting. The medical home can inform you of upcoming appointments to help with appointment keeping, or when a client misses an appointment to help with rescheduling. The screenings that you routinely conduct will be sent to the care coordinator, and particularly for concerning screening results, these will be shared with the doctor. The doctor and home visiting program can coordinate how to address the abnormal screenings, and other coordination activities may involve discussing a specific concern, clarifying advice, record requests, and referrals. Your supervisors will conduct trainings that go into more detail about workflows. Workflows may eventually include how to use the web-based health information exchange known as CRISP to access health records and communicate information about your clients. This slide shows an example of the care coordination form you will use to track contacts between your home visiting program and the UFP medical home for the pilot. Your supervisors will train you how to use the form. We are excited that We Care to Coordinate Quality Improvement Program will start very soon. We will be evaluating the outcomes of the pilot, including your clients and your satisfaction. We hope that better coordination will enhance quality of care, reduce costs, and most importantly, improve outcomes for children and families. Thank you so much for your attention.